Okay, so good afternoon, everybody. Thank you for joining our today's webinar, which is entitled Rehabilitation in Ataxia, Current Evidence and Practice, and will be presented by Ludger Schöls from the Hereditary Institute for Clinical Brain Research at the University of Tübingen in Germany. My name is Sanja Hermans, and I work at the Institute for Medical Genetics at the University Hospital Tübingen in Germany. And we are coordinating here in Tübingen the European Reference Network for Rare Neurological Diseases, where I am responsible for the training activities. So almost 1 year ago, we have started this joint educational initiative together with another European reference network, the one for neuromuscular diseases, and with the European Academy of Neurology. So this is our 28th webinar since then. So, and I'm very glad that you're here. Further, I would like to give some short information on the European reference networks. They are groupings of expert centers across Europe, and they have been established in 2017 by the European Commission in order to intensify and to facilitate the collaboration and to enable exchange of knowledge and expertise between these healthcare providers. And of course, the final goal is to improve the quality of care for the patients with rare diseases in Europe. So there are in total 24 European reference networks, and we are coordinating one of them, the one for rare neurological diseases. We have at the moment 32 full members, and in the dark blue countries here on the map, and 10 affiliated partners in the light blue countries. And the network will be expanding in the next year with other approximately 30 new partners, new healthcare providers. So our network is covering 6 disease groups, which you can see listed here. And today's webinar has a topic from the disease group Ataxia and HSP. Okay, a short general information about our webinars. Today they have focus on rare neurological, neuromuscular, and movement disorders. And today's webinar has also a supplementary focus on neurorehabilitation. We have 40 to 45 minutes presentation and 15 minutes of questions and answers at the end. So please do not hesitate to write your questions in the Q&A box. You can see the button in the lower toolbar. So this webinar is recorded and will be published on our website. It's this one here. I'm blending it in. And at the moment, we are working on the creation of the webinar program for 2021. So very soon you can see all the topics that will be presented in 2021 on this website. And you can also check another part of our website, which is the Disease Knowledge Hub with a focus on ataxia. We have different disease knowledge hubs. Your browser will open at the end of this webinar. It will open post-webinar satisfaction survey. So please give us your opinion, your feedback. We will be very grateful and happy to hear what you think about the webinar. You can propose also topics for next webinars, etc. Okay, so of course, we have here our target audience are clinicians, but we are always also considering the other perspective, the perspective of the patients. And Mary Kearney, she's our patient representative for the disease group Ataxia and HSP, and she has recorded a short video which I would like to show you now.
My name is Mary Carney. I come from Ireland. I'm a patient advocate for Ataxia, which is part of the Rare Neurological Disease group of the European Reference Network. My job is to make sure that the voice of the patient with ataxia is heard throughout the ERN, and I feel I am well placed to do this as I have 2 children with ataxia. I know the daily needs and challenges that present to those with ataxia, and I feel I can bring this information into the ERN network discussions, activities and decisions. I am a member of Friedreich's Ataxia Research Alliance Ireland and Rare Diseases Ireland. As the aim of the European Reference Network is to share, care and cure rare diseases, I feel it is absolutely imperative that patient advocates, clinicians and researchers work together. I fully support this initiative of specialised training in rare neurological diseases, as I feel the sharing of information in Europe and worldwide will help to improve the care for those with ataxia. And the sharing of information, ideas, research results will help to bring a cure for ataxia to all sooner rather than later. It is my pleasure to meet you all.
Okay, so this was Mary. Thank you, Mary, to have your perspective. And now we come to our speaker. I would like to present Ludger Schöls. He's actually only 2 kilometers away from my office here. So we are both in Tübingen. He has obtained his medical degree from the universities of Bonn, Tübingen and Edinburgh. And he has performed his specialist training in neurology at the Ruhr University in Bochum in Germany. And for his habilitation, he was working on clinical and genetic characterization of hereditary ataxias. His current position is full professor of clinical neurogenetics at the University of Tübingen. And other key positions or activities that he has are section head of the Hereditary Institute for Clinical Brain Research. He's also deputy director of the Department of Neurology and speaker of the Center for Rare Neurological Diseases at the University of Tübingen. He's also a group leader at the German Center for Neurodegenerative Diseases and also a clinical coordinator of our network, of the Network for Rare Neurological Diseases. He's also doing research, and the 2 main foci of his research are neurogenetics, so discovering genetic causes of neurological diseases, and genotype-phenotype analysis. But his group is also performing translational research, natural history studies, biomarker development, and interventional trials. Furthermore, he's working on disease modeling in induced pluripotent stem cells derived neuronal cell models, and also on in vitro and in vivo studies of innovative compounds. So we are very happy to have such an expert in this field with a very long experience in the field of ataxias today. And I'm very happy, and thank you, Ludger, to have accepted this invitation. And now I will stop sharing my screen and the floor is yours.
Yeah, thank you, Sanja, for the kind invitation. I need to find my presentation first. I hope that this works. Yes. Can you see my screen? Okay.
Yeah, great. Mm-hmm.
Okay, so thank you very much for the kind invitation and for the chance to give this webinar here today on a very interesting and rather young topic, rehab in ataxia. This webinar, I will give a short introduction to cerebral ataxias and then focus on studies on physical therapy, video game-based training adapted to physical activities, very short notice on speech treatment in ataxias, and then we'll present some of the open questions. The learning objectives, I would hope that after this webinar, you will be able to know various beneficial rehab strategies in ataxias, be able to appraise effects of physical therapy, exergames, and speech therapy, understand factors that influence the success of these strategies, and be aware of open questions in ataxia rehabilitation. First of all, I would like to start with a short video poll on the background of your expertise in the field of ataxia. Would be very interested to know from which fields you are coming from. So Sanja, you...
yes, I have started just right now the poll, and we will leave some 40 or 45 seconds to the attendees to respond. Okay, 10 seconds left. Okay, so then 73% of the attendees have already responded. I will show now the results.
Oh, that is amazing. The majority of physiotherapists, that is really something new, I guess, and I'm very happy about it and a little bit nervous because I'm a neurologist and not a physiotherapist, and hopefully I can address your questions as well and you don't find too many mistakes in my presentation. Okay, can you close that?
Yes.
No, my screen is no longer responding.
You maybe try to put the mouse on the, and then click with the buttons on your keyboard.
Yeah, you're right. Thank you. Okay, first, a few general remarks concerning ataxia. Ataxia comes from the Greek ataxia, what means something like out of order. And what is out of order are the movements, the coordination of movements. In general, there's a lack in coordination due to problems in the precision and the timing of movements. And you need a very precise and well-timed movements for almost all of the everyday efforts like gait, for stance, that you don't fall, for dexterity, for your articulation. Many muscles are involved in speaking, and for the coordination of eyes. They have always to move around. If you move, the eyes need to keep a stable view, and that is a lot of coordination that is done by the cerebellum. There are many causes of ataxia and of variable etiology. There's vascular causes like cerebellar stroke, autoimmune diseases like multiple sclerosis may cause ataxia, infections with viral cerebralitis as an example, metabolic changes with vitamin deficiency or Wilson's disease, toxic events like alcohol abuse or some drugs like phenytoin. Tumor may affect the cerebellum and cause ataxia. And for today, we focus on the neurodegenerative diseases and the hereditary causes of ataxias. And as you can see on the right, there are many genes now detected for dominant or recessive forms of ataxias, and the numbers are still increasing. The cerebral ataxias, you can also, apart from genetics, divide it according to the phenotype. You have some types with pure cerebellar ataxia syndrome, but many ataxia plus syndromes. And these non-cerebellar manifestations need to be considered and integrated in an overarching treatment concept. You need to consider spasticity, peripheral neuropathy, afferent deficits, Parkinsonism, dystonia, tremor, and myoclonus, because it interferes with the movements and need to be included in your therapy concept. Ataxias do not only differ concerning the phenotypes and genotypes, but also concerning the neuronal structures that are involved. The most simple case could be that only Purkinje cells are affected in the cerebellar cortex. That is the example of spinocerebellar ataxia type 6. You find predominantly cerebellar nuclei affected in SCAR3. But there are also diseases primarily affecting spinocerebellar afferent tracts like Friedreich's ataxia. And you also have diseases that heavily affect the brainstem, Olivoponto cerebellar ataxias, or the basal ganglia like MSA and SCAR3. This is likely to influence the learning circuits that are remained for motor learning in such a disease, and by this influences the success of training strategies. Concerning treatment, there is now emerging mechanism-based causative treatment approaches at the horizon for some of the genetic causes, but not yet available, hopefully in the near future. What is available at the moment is symptomatic treatment by drugs like 4-aminopyridine or 2 positive studies on riluzole, but this is almost difficult and not a final solution for the patient. Last week, we heard about non-invasive cerebellar stimulation in a webinar from Bart van der Warmberg. And this is another field that is emerging, but not on routine availability at the moment. Should be aware that sometimes you can help patients with prism glasses, example for diplopia, but the cornerstone in all the treatments and for all types of ataxia is exercise rehabilitation. Talking about treatment in ataxias, I don't want to miss to mention the non-cerebellar symptoms because they are frequent and they are often treatable. So if you see a patient, have a look on spasticity, dystonia, Parkinsonism, restless legs, dysphagia, neurogenic bladder disturbance, dysesthesia, and cramps, because all of these are treatable and can be beneficial to your patient. So now focusing on exercise and rehabilitations. The key questions for me are, can patients with cerebellar ataxias that affect the whole cerebellum improve their performance by training? My answer, at least, is of course yes, otherwise we would not have this webinar today. But is motor learning still possible if the degenerative process affects the cerebellum as a whole? Where does it take place? Which structures are involved or need to be preserved? This is a question that in the end will be turned out to be still open, but should be in our minds. What is the optimal training? What is the best concept, and what is the duration a training unit needs and the frequency of training units? And how can we measure the training effects? Most patients with ataxias get some type of physical therapy, and we all believe that it's helpful, but how can we measure that? We will see some studies use ataxia scores, others the back balance scale, the fall inventory or fall diary is an alternative. You can go for computer recording of the movements or for a goal attainment scale or for the activities of daily living. For the beginning, I just want to challenge you again a little. Which therapies do you recommend to your patients with cerebellar ataxias? Here's a choice of 10 There are more, but no more can be included in the Google poll here. More than one answer is allowed. So you can tick all the ones you believe that are effective. Sanja, are still there?
Yes, I will leave another 15 seconds the poll open, because there are those 10 possibilities so that people can read everything and choose everything. Until now, there are 70% of them that have already responded.
I apologize for the German Mehrfachauswahl. Means that you can choose as many as you want.
Yeah. So, okay, and here are the results.
Okay, so at least 10 to 15% believe that all of these are somehow effective. I will not, I don't know, because there are only a few studies and none addressing Voiter or Bobat, which are classical neurological concepts, but not evaluated at all in the studies I will present you in a minute. Isometric training is also something that is not evaluated. Massage and relaxation also not evaluated. There's one study with vibration, but using vibration only in addition to more classical concepts. Coordinative training is that is really evaluated best, and I'm very happy to see that most of you voted for that. No studies for aqua aerobics. Treadmill, yeah, there is a very interesting study I will present, but not a conventional treadmill. Ergometer training is difficult, not evaluated, and balance training is overarching together with coordinative, the most the best studied concept. Okay, can you close that again, Sonja?
Yes.
No.
Yes, you should be able now to go further.
No, it doesn't work.
Well, maybe try again.
Yeah, okay.
Yeah.
I need to click. That's okay. In the presentation now, I will focus on physical therapy, video-based training, adaptive physical activity. I will only strive very shortly occupational therapy. I can't say anything about hippotherapy because there are no studies, nothing about aqua aerobics, no studies there. And there's one study about speed therapy. Which training program does help in cerebral ataxias? In a recent review by He and colleagues, you see in the on the right lower end, they listed the available studies and came to up to with 34 studies in total. To date, 7 randomized control trials have been published on physical therapy in ataxia. These studies included between 6 and 42 patients, and all were restricted to adult patients. 4 studies were restricted to a single genotype, 2 times Friedreich's ataxia, 1 time SCAR2, and 1 SCAR6 study. The study concept spanned between 4 weeks and 24 weeks, almost half a year, of supervised training, and follow-up has been done in only 3 studies ranging from 24 weeks to 5 years. I would like to show you more details of the very first randomized trial that has been performed by a Japanese group. Here it is. It has a delayed onset design, meaning that half of the patients started immediately with the training. It's a 4-week inpatient training, and the other patients had to wait 4 weeks and then started after 4 weeks after a second evaluation. So a delayed onset design as a randomized controlled trial. Included 42 patients. It's one of the biggest studies done ever, already 8 years ago. Included patients between 40 and 82 years with pure cerebellar ataxia, mostly SCAR6 and SCAR31 patients from Japan. 4 weeks inpatient training, very intense, 2 hours of coordinative training or training of activity of daily livings on working days. And in Japan, you are not allowed to have a rest at the weekend. And at weekends, there was still 1 hour of training, either coordinative training or activities of daily living. The group that got immediate treatment did significantly better after 4 weeks in terms of SARA, gait speed, and the activities of daily living, as well as falls. And this effect lasted for 24 weeks, at least in part here for the SARA. This is the post-intervention improvement, and then it's slowly getting worse again. And this is the case also for the gait speed and for falls. You have a very clear effect, very impressive on falls, 1.5 falls in the beginning and 0.3 after 4 weeks of training. So very effective, but it got lost over time. Now I want to continue with the studies that are not randomized, but still controlled trials. There are in total 16 non-randomized controlled trials with up to 29 patients, including 3 single case studies. They are all in adult patients, and only one that is restricted to one genotype, Friedreich's ataxia. They included 2 weeks up to 3 months of supervised training, and 9 studies had a follow-up up to 1 year. I would like to highlight 2 of those. The first one was actually 2 studies, and the second one is the long-term follow-up of the first one, and a study on fall prevention. Starting with the first study is one of our own group, I have to admit. It's on intensive coordinative training. It's an intra-individual control design. That means that we have seen the patients twice before they got therapy at baseline, and then after 8 weeks to compare for everyday differences in performance and spontaneous changes. And then all the patients got 4 weeks of intensive training, 3 physical therapy units per week. In 4 weeks, this sums up to 12 physical therapy units per patient. Then we had a follow-up period where the patients were supposed to do some home training, as well as in the long-term 1-year follow-up period. This coordinative training has been designed by Doris Boitz, that's her in action. And this concept believes in the following principles: active release of fixed movement patterns. So trying to get rid of some unhelpful movements patterns that have been the patient came to because of balance problems. Training of static balance, training of dynamic balance, whole body movements, falling strategies and steps to prevent falling, movements to treat and prevent contractures. And from this, she always selected individually a few exercises only that should be frequently repeated in the home training. So not a training program of half an hour with always different exercises, but only few exercises, frequent repetitions, and that is her belief that this does the best change. Indeed, you can see there's no much change between the first visits. Remember, this is the intra-individual design, control design. So there was just the normal training they always had. And then the 4 weeks with 12 units of physical therapy started, and you can see an improvement, a drop in the ZARA score for almost all patients, individual patients here. And these effects remain stable within the 8 weeks of home training. So after 12 weeks from baseline, you still have very good effects. It's an impressive improvement of 5.2 ZARA points. That is the natural progression of disease, for example, for more than 5 years in Friedreich's ataxia, or at least 2 years in more rapid type of ataxia like SCAR1. This improvement that is shown here in ZARA was also present in the digital or computerized movement recordings on the back balance scale that is often used by physiotherapists, and in the goal attainment scale, goals that the patient defined, and I will show you examples on the next slides. These, as I already said, these effects persisted after 12 weeks, with larger benefits in patients with cerebral ataxia than afferent ataxia. Here are some examples. This is the example for the static balance, this dynamic balance training, and this is whole body training for coordinative training and relevant for activities of daily living. This is the example for the goal attainment score. The goal attainment score is a patient-centered outcome measure with the performance at baseline that is given as a score of -2. Then you have 4 steps up to +2, what is much more than expected, and 0 is that what the patient expect to reach with the physical therapy. And here is an example. Patient is focusing on walking around a table with small distance without swaying. And when he started in the study, he was only able to walk around the table by touching the table. And in the end, he reached +1. He was able to walk around the table without touching the table and was able to look around sometimes. Here are some more examples that have been reached by the patients in this trial, and what you can easily see that there's only one patient who had a minus, meaning that there was only a small improvement, less than he had expected. 0 means they have reached what they expected, and the +1s all reached more than they had expected. So I think this is a very important way to evaluate the effects of a study, because this is directly what the patient is looking for. On the other hand, you have a very objective measure, the computerized movement analysis with 41 reflecting markers in a Viking system. You can measure all joint movements here, and this gives you excellent analysis how joints are moving, and you can easily see that during a walking cycle here, the movement is not the same. If an ataxic patient is walking, there's quite a variability, and that improves a lot in the study with this coordinative training. The second study, or the long-term follow-up of this study, after 1 year, still shows, this is the baseline again here, and then you have the immediate effect of the treatment, and then after 1 year of follow-up, you see some worsening again, according to the degenerative nature of the disease, but on average, it's still better than at baseline. So after 1 year, you still profit from this training. And this is shown here in the back balance score. The first group is the baseline after 4 weeks and after 1 year, and the same for the Cerebellar group and the afferent group. Here in the ZARA, you see that the improvement lasts in the Cerebellar group, but the afferent ataxic patients are doing worse. The effect size in this study correlated with the intensity of training at home. It improved everyday functions, and patients with cerebral ataxia, as I said before, benefit more than with afferent ataxias. Now I come to another study. It's from the group in Nijmegen that focused on gait adaptability for the prevention of falls, establishing a gait adapting training on obstacles avoidance and dynamic stability during adaptive gait. And they included 10 patients and with 10 sessions of 1 hour training in 5 weeks. And what they used is a treadmill with visual stepping targets. And then they introduced obstacles projected on the belt, and the patients should prevent these obstacles. And after only these 10 training sessions, they have shown improvements in the obstacle tasks, even the ZARA, and also half the falls have been reduced to half of from baseline. And this here is a little bit difficult to read. The columns indicate the percentage of steps in which the anterior posterior and the medial lateral margin of stability was within the reference values. The dashed line here and there indicates the obstacle crossing steps. And what you can see is that more steps are within the normal limit in the post-crossing. So patients were better able to cope with obstacles on their way on the treadmill. I now want to move on for video-based training, virtual reality and video game-based training. There are 7 studies available now which have been performed in ataxia. Three of them specifically addressing young patients and kids using the Xbox Kinect system or the Nintendo Wii platform for commercial games. These studies included 10 to 30 gaming sessions within 1 to 10 weeks. Again, I want to highlight the first study that has been done and another one for more severe ataxia. Starting with the first video-based training published in 8 years ago now. It included 10 patients, young patients, 11 to 20 years old. It started with a 2 weeks period of lab training and 4 weeks of home training with Xbox videos as indicated here, table tennis for upper extremity coordination, light race for lower extremity training, and 20,000 leagues for upper and lower extremity training. This video, if it works, this young boy who is a little bit overweight, in the beginning is not very fascinating doing his table tennis, but getting more and more involved and coming to leg movements and whole body coordination, just showing that this is a way to train that is highly enjoyable for the patients. You again have this intra-individual control design, these first 2 visits without intervention, and then you have the 2 weeks period with some improvement, 2 points on the SARA scale, and even more improvement after 6 weeks of home training. This clearly shows that you can reach with video games meaningful improvements, not only on SARA, but also on the digital movement recordings. And there was a clear correlation between training intensity and the benefit. The advantage of these systems are very clear. They are rather cheap. They can be done at home. They have a clear fun factor with high motivation, and they really give self-empowerment to the patient. Whereas in the first study, the patients were rather mildly affected, all were able to stand and to walk. In this second study, kids with a more severe affection were included. They were between 6 and 29 years old, and the SARA was up to 29 points. It consisted of 2 times 6 weeks of training with intermediate adaptation for improvement. And these were the 4 games that have been used. They all can be played in the sitting position. Hopefully this video works now. How this little boy moves his trunk to keep the bowls here on the table or move them to the holes. So this is a really terrific training for the trunk movements. And you can play the same thing, of course, if you are able to stand. So some patients improved that much that they could for the second 2 weeks in a standing position. And similar, there are more similar games listed here that can be used for this training. Same effects, 2.5 points on the SARA scale. And again, the training intensity correlated with the effect size as nicely shown here. You have the training intensity in hours per week and the improvement in SARA. You clearly see the correlation. And again, you not only SARA and the movement recording, but also the benefit in the goal attainment score. Okay, coming to the evidence for adapted physical activity, there are only very few studies published so far. There's one study with only 1 participant for partner tango dance, and 1 prospective study for a Tai Chi performance with 10 participants, but there's not much done so far. Finally, speech therapy. Again, there are only very few studies. To be precise, only 1 pilot study that has been done in 7 ASACS patients with a 4-week program, delayed listening and delayed listening feedback. That means you listen to what you have been on your performance of yesterday to get an impression what you want to improve. Then you get real-time visual feedback while you are speaking, holding a vowel, for example. This is the feedback. And you get a performance feedback in comparison to the day before, so that you can really see your improvements. And with this concept from Adam Vogel from Melbourne, there was a clear improvement in the intelligibility of speaking on a monologue as well as on passage reading, and in the naturalness of the speech, rated in a blinded assessment, as well as on acoustic measures of speech. So this is only the first study, but clearly successful, and hopefully more work is done in this field. With that, I'm come to my summary. I hopefully could show you that physiotherapy is able to improve balance and coordination as well as daily activities also in degenerative ataxias. Long-term studies demonstrate long-lasting effects. Studies support training protocols with active exercises. Training by whole body controlled video games, extra games, is enjoyable alternative to classical physiotherapy, and beneficial effects seem to depend on intensity of training and continuous training to preserve benefits. And with that, I'm back to the last video, Paul. And I would like to hear from you which training regime you would recommend to a patient of yours with a mild to moderate ataxia, meaning something like 10 points on the SARA scale. Again, you can tick more than one box, but be open and honest. There's no right or false.
Okay, 10 seconds left. Okay, I will now show the results.
Okay. I like it very much that most of you voted for a limited training of only a few minutes, 20 minutes, several times a week. Of course, it may be better to go for 2 hours in 7 days, but I personally don't know many patients who do such an intensive training. So this is realistic. And that's actually what I recommend to my patients as well. But we must be aware that for none of these alternatives, we really have a proof. How often physiotherapy has to take place on the long run has not been studied. We don't have studies on the duration of a single training unit. We don't have only very few combinations with occupational therapy, only one, the Japanese study I presented in the beginning, and on adapted physical activities, we have almost nothing. What I mostly recommend, but you can go different, is 20 minutes of study for 4 days, and adaptive physical activities, something people like dancing, like walking in a challenging surrounding like woods or the mountains, adapted to the status of the ataxia. If you can leave that, Sonja, I can come to my very end. So this leaves us with open questions, the same questions we had before. What is the optimal rehab concept? The frequency and duration of training sessions, we don't know. There are no studies for that. Predictors of training success. When to start with therapy? There are good hints that it may be helpful to perform training or also in pre-symptomatic stages of spinocerebellar ataxias And this may delay the disease onset or the disease progression, but this has not been studied yet. Some training program or the same training program in all stages of the disease? Probably not. We need to adapt to the individual feasibility and preferences of the patients. We still don't know which compensatory motor learning strategies are preserved in early and late stages. And to that end, I would recommend a very nice editorial from Dagmar Timmermann-Braun and Oliver Donchen in Brain last year, where they elaborated on the different remaining circuits that may be used to improve the performance starting from the asymptomatic, pre-symptomatic patients to late stages of ataxia. There are still many more other open questions. We do not know where this cerebellar motor learning does take place in cerebellar diseases. What is the morphological equivalent? And you may come up with many more questions for sure. So the key points for me are rehabilitative training is effective in cerebral ataxias, and I hope I could show that. Success requires individually tailored rehabilitation program and active involvement of the patient. Different training for ambulant and wheelchair-bound patients are needed. Consider individual preferences to make training enjoyable. It's important that it's done often and for a long time. Effect size correlates with training intensity and strongly depends on continuous training. With that, I'm at the end. I thank you for your patience and your interest. And I want to thank to Doris Brötz, who developed here the Tübingen physiotherapy concept, Winfried Ilk, who is very successful in the movement recording and all these studies, and Matis Novcik, who is the motor behind these physical therapy studies here in Tübingen. Thank you. And now I would be happy to get some questions.
Yes, thank you, Ludger. I think we are now receiving or have received the first question. In the meantime, I just wanted to say that we may integrate those videos that didn't work now during the live presentation in the recorded webinar that we will publish on our website. So if you can send me those short videos, Ludger, I will insert them in the recorded webinar so that people can view them from there too, because I think they will be interested in seeing them.
Yeah.
Okay, sure. So there is a first question from Thorsten Schmidt. Are there any disease-specific trainings recommendable, or does the effect of training basically depend on the disease severity and individual symptoms rather than on the genetic type of ataxia, or just on the type of ataxia?
Yeah, very good question, but no answer. There are no studies done. There are a few concepts that have been evaluated in one genotype, so that you at least can say this concept worked in this genotype, but and there's no comparison between different concepts within one genotype. So the evidence, most evidence is not genotype specific, and I'm not aware that there are some aspects that are especially important for one genotype. The afferent ataxias need to consider that the sensory feedback is less than normal in their concepts.
Mm-hmm. Okay, thank you. Another question from Bernhard Landwehrmeier. What is your view on the use of balance wear, torso weighting and similar weighted vests or similars? Does this approach, in your opinion, work? Is it worth trying?
Interestingly, it's not included. Such studies are not have been performed in the Munich group and some other groups, as far as I'm aware of, some times ago, but it never reached these reviews for physical therapy because the design was not that clear in its effect. It was no clear study design. From my experience, it is not very helpful. We believe in performance, in movements that are as close as possible to activities of daily living and not artificial, using weights that hinder you in hypermetric movements. So no studies that clearly show the effects, and from our belief and concepts, I would not support that.
Right. Another question from Vinny Malo. Which is best physical or occupational therapy for ataxia?
As I've shown, there are many different concepts, all worked. It's hard to compare the effects. You can go for the SAR scale that has been used in most of these studies, but you must be aware that without blinding, you have some, what do you want to call it? You depend a little bit on the rating of the doctors who all want to see a success. So that is nothing that you can really easily compare. So what all these concepts that were successful have in common is that they are going for active coordinative training, no single successful study on relaxation or massage is effective, but they are all going for active training.
Right. Okay, thank you. Another interesting question. Do you prefer simple task with high repetitions or task-oriented approach for mild cerebellar ataxia?
You should go for challenging tasks. So something the patient cannot easily do, but should repeat this task often. And once it is reached, you may adapt the concept and go for a second task after a few weeks.
Thank you. Would you recommend proprioceptive neuromuscular facilitation for ataxic patients?
Not evaluated in the studies that I'm aware of, but I could imagine that it is maybe especially helpful for afferent ataxia, but nothing that has been shown so far.
Okay, another question from Rajesh Kandadai. Many thanks, Ludger. Is there a rehabilitation schedule that has been designed by Doris available for the patients to continue at home, taking help from local physiotherapists?
Yeah, the concept by Doris Preuss has been published. It is attached to the paper from with Winfried Ilk as the first author from 2009 in neurology, and there's a detailed study published by Doris Preuss directly in the Physiotherapist, but I'm afraid it's in German. Anyway, there are a lot of images, pictures that illustrate that and may be helpful.
Right, okay. Another one, are there trainings offered in Germany for physical therapists working with ataxia? Are you aware of this?
I'm not aware of any such training, but I know that Doris Preuss, who is still working here in Tübingen, trained some colleagues and probably would be willing to do so. So if you Google her name and Tübingen Physiotherapy, then you should get contact to her.
Okay, another question from Bernhard Landwehrmeier. is your impression that motor learning is more impaired in disorders combining cerebellar and striatal lesions or impairments than lesions restricted to either region?
Very interesting question again, Bernard. There's no study on that. My impression, I would expect that the combined lesion really is the problem. That I'm thinking of multiple system atrophy or SCA3 or multiple system atrophy. Then there you have a real problem with training, but that is also a problem of the rapid disease progression. So it's hard to say whether it's the rapid disease progression or the combination that is making so difficult to get improvements in multiple system atrophy.
Another question was asked in the chat, but now I somehow don't see that box. Okay, now, have you heard? Yeah, I think this was, this was addressed. Okay, another remark of Alan Thomas, interesting comment about balance vests. Patients have seen varying degrees of improvement, albeit temporary. As a patient myself, I have tried one but have not purchased one. The low cost might be inviting to patients. Okay. Another question, is there a connection between Olivoponto cerebellar ataxia and infectious prions?
Okay, now we are leaving physiotherapy, but normally you call Olivoponto cerebellar atrophy or ataxia a degenerative disease, and Prion disease is a different etiology that affects all these systems in the end. So goes along with a similar, can go along with a similar picture, but it's a completely different etiology and affects many more systems, cortical systems as well.
Thank you. And I think now we don't have any other questions. So thank you very much, Ludger. We have another ataxia, again, ataxia-related topic in 2 weeks' time with a pediatric focus. So the topic is development of Sarah Home and will be presented by 2 clinicians from Rome. So you can, as always, register from our website and hope to see you there. And thank you for joining this webinar and see you soon. Bye-bye.
Bye.